Hi, listeners.
Hello. Welcome to the MedInsights Unleashed podcast
With your hosts,
Z.
and John. Hi, Zara.
Hi, John. We always do this. We always wait for who's going to break the first ice.
Well, we're in the field of, with our guest speakers today, dealing with a lot of breaks, a lot of broken bones, and they're back.
Well, an exciting episode as well on knee replacement, but I will say this is, different from the injury I've just had. I have a terrible sprain in my right ankle. And it is the most debilitating thing when someone is active and you just have to sit and give time, which I'm not very patient about. So I'm definitely looking forward to this episode.
Yes, it's an episode following up from my recent fracture where I was sent by my surgeon, who happens to be on this call, for PT. Every second patient was coming in with knee replacements, and it's very, very common these days. I'll get both Ari and Lewis to introduce themselves from the Northwell Health Orthopedic team. They've already done one great episode with us called Nail It on hip fractures. This is a second episode now on knee replacements. One of the things that I see being an EMT is the pain that's occurring with knees and knee replacements, as some patients have really good outcomes, other patients not so good. Thought it was a great topic for us to cover today. So I'm going to ask Dr. Ari Goldman, MD from Northwell Health Trauma Team, and Lewis Collins to introduce themselves for the listeners again, as this is a new episode, and we're going to slip into knee replacements and some of the issues around knee replacements.
All right. Hello and good afternoon. My name is Dr. Ari Goldman. With me is Lewis Collins. We are heavily involved in the care of orthopedic patients. I'm the associate chairman of our department. So I'm heavily involved in the quality aspects as well. And I also have the privilege of seeing how different surgeons do the same procedure, as well as some follow-up and differences in post-operative courses, and also differences in indications. One surgeon may think that someone may benefit from a knee replacement and one person may not. So we're excited to be here. We're happy to jump into the depths of knee replacements and try and answer some questions and try and make sense of all of the information out there, because it can get confusing.
Yes. And eventually we'll all
Definitely.
need a knee replacement, and I don't mind a new bionic knee, I'll be honest.
So, Ari, talking about knee replacements, and Lewis, my first question to you is, what's the structure of the knee? And also, basically, what's driving the prehistory to a knee replacement? Is it arthritis, bone disease of some description? How does a patient end up having a knee replacement?
Or is it genetic? Because I know, is there a genetic predisposition to?
That's a very detailed question. I guess we'll kind of break it down into parts here. The first part of understanding everything is what the knee does and what it's made of. The knee is a hinge joint. It's a major joint in our body. And a hinge joint basically works in extending our knee and bringing it back. They call it flexion. And it's really important because our largest muscle groups, our hamstrings and our quadriceps, are all involved in walking and ambulating and all attached in and around the knee. So the knee is comprised of three bones. It's the articulation point of the patella, which is the kneecap, the femur, the distal aspect of the femur, and the proximal portion or the top half of our tibia. We sort of divide it up into three compartments. We have a compartment where the patella sits against the femur and it sits in a little knot called the trochlear groove. And then you have a medial compartment or an inside compartment of the knee comprised of the proximal tibia, the top of the tibia, and the distal femur. And you have what they call the lateral compartment, which is the outside of our knee. Like if you were to rub your hand down your leg, And that's also comprised of the distal femur and the top of our tibia, the proximal portion of our tibia. To go along with that, as a hinge joint, it's coated in cartilage. And the cartilage is the smooth surface that allows our joints to glide and move freely and smoothly. We also have our menisci in there, which are semicircular type discs, which act as shock absorbers. So when we're thinking about the knee, we kind of think about it a little bit as the cartilage and the menisci are kind of like the tread on a tire. And as we age, as we move along with genetic conditions and things like that, the process is that this cartilage, the smooth portion of the joint, wears out over time. And, it can come from a number of reasons. Some of it is genetics. Genetics, we know, are becoming more and more involved in predisposing people to conditions. They can have different thicknesses, different softnesses. Sometimes it's anatomic variance. Some people have different shaped menisci than what's considered normal. The other aspect to it is weight. The heavier and, people with high BMI put more wear and tear on their joints because of weight and forces across the joint. And then we also have genetic conditions, things like rheumatoid arthritis, lupus. In some patients, chronic long-standing vitamin D deficiency, that all play a factor in knee health and the eventual breakdown of the knee.
How important is weight impacting the knee?
Lewis made a very nice analogy just before using it to tires, where we also kind of think of cartilage inside our knee similar to our adult teeth. Adult cartilage is very similar to adult teeth, where not as far as its consistency, but as far as its ability to repair itself. For example, if you chip a tooth or there's damage to your tooth once you're an adult, that tooth can't heal, it can't get fixed. So if you crack a tooth or there's a cavity in it, there's an infection in it, right? That tooth can't heal. So very frequently what happens, you go to the dentist, you go to the oral surgeon, you get a fake tooth put in. Same thing as what happens to our joints. The cartilage inside our joints cannot regenerate. It cannot heal. What you have as far as cartilage goes, once you enter puberty, that's what you have for the rest of your life at this point in time with medical technology. So once that cartilage inside the joint wears away, the wearing down of cartilage is what we call arthritis, a breakdown of the joint. That cartilage provides the shock absorbency and the gliding for that joint. Now you can imagine, just like with getting back to that tooth analogy or that tire analogy, say, for example, you're someone that grinds your teeth at night and you're wearing that down. We can equate that to something like obesity, where there's more wear and tear on the joint because there's more weight being put down. If you grind your teeth, you're putting more weight through your teeth. If you're a heavier person, every step you take, you're putting more weight through your knee. There's a higher chance of the cartilage that's there of breaking down. And similar to the tire analogy, if your alignment is off on your car, if the tires aren't evenly inflated, they're going to wear down faster. You're going to lose tread. Same thing inside the knee. If your knee is malaligned, if you don't have the proper alignment of your limbs coming from your back, coming from your hip, coming from your ankles, those joints are going to wear down faster. Sometimes the knee and the knee arthritis that occurs, that loss of cartilage, can be due to something going on inside the knee, but it can also be due to something, another part of your skeleton that's away from your knee and can cause increased wear on your knee. So knee replacements can be quite complex because people with knee arthritis, the first thing you have to do is figure out if it's coming from the knee itself or if there's something else that's leading to it, because that may also need to be corrected in order to get a good outcome with the knee replacement.
So before we head into more of the topic of the knee replacements, two questions I have. For example, myself, I'm very active. I run, I hike, I do it all. And I have really poor knee health. And I'm going to say it's attributed probably to genetics. So for me, it's overuse, like your analogy of the tread with the tires, right? It's overuse, it was breakdown of my cartilage. Are there preventative measures or no?
Without a doubt, there are things that we can do to increase the longevity of our joints. And it's going back to the things that we were sort of just talking about. Cartilage, actually, the coating to our joint actually likes to feel weight, and it actually needs to be stressed, and it actually needs to be used in order for it to be at its most effective state in allowing your joints to glide. So exercise is actually very much recommended for knee health. Now, the type of exercise that you perform, that's really, where the area is where you can really make a big difference. Running on pavement, running on hard surfaces, running barefoot, running with poor footwear. Those are all things that put an extreme amount of stress on your knee joint and can cause your knee to wear down faster. Running on a treadmill or running on a track puts less stress on your knee than, for example, running on pavement or asphalt. Similarly, a bike or an elliptical puts way less stress on your knee than running. So if you're someone that feels like you have early onset sort of knee pain or knee problems, and someone's a runner, so to speak, cutting back on the running and you doing other cardiac type exercises, endurance type exercises, can definitely help promote the longevity of your knee. So, that's important too. And also when you run, if you have some malalignment in your ankle or malalignment in your hip, that's going to be exacerbated with running, whereas you doing a different exercise where you're not necessarily bearing weight on it, it may be more beneficial.
Can the misalignment then from a hip to the knee, if it's not fixed in advance, have an impact on how that knee replacement is going to perform in the future? Could that explain why some people have great outcomes versus some have failures because the alignment is critical?
Yeah, I mean, very, very much so. The knee bone's connected to the hip bone type. And when patients get evaluated for knee replacements and get evaluated for their arthritis, one of the things that we like to try and do is we like to take x-rays with patients standing and get an x-ray from their bottom of their spine and their pelvis all the way down to their feet and ankles. This way we can see the alignment. If we just take a small snapshot, an x-ray just of the knees, sometimes you lose the forest through the trees. Sometimes there may be something else going on that you may not know about that may affect your outcome. Similarly with the back and spine. If you have a scoliosis that's throwing off your alignment higher up and your pelvis is tilted, and that gives you, different leg lengths because your pelvis is tilted and your legs are the same length, but because of the pelvic tilt, one leg appears longer than the other. That knee may wear out faster than the other knee because you're constantly putting more weight on it.
The other question I had was Lewis had mentioned, for example, vitamin D deficiency. So can we just talk a little bit about like diet and is there a need that, each of us should be supplementing with vitamin D to enhance bone health, or what are your thoughts around that?
The vitamin D and bone health comes into play when we're talking about the bone quality. Vitamin D has very little to do with articular cartilage, but what it does have to do with is the bone that sits right underneath the cartilage and gives it that structural support. So if you have poor bone quality sitting underneath your articular cartilage, the base is softer. It's like building a house on a swamp and not having a steady foundation. It's going to be that house is going to sink. Same thing, that the cartilage is going to depress. It's going to sink because its support underneath is a lot not as sturdy as it should be. As far as other nutrients, there's a lot of there's vitamins, hyaluronic acid, vitamins,
Glucosamine, chondroitin.
yes, those glucosamine and chondroitin, and those are to help, quote unquote, promote joint health. But really, there's never really been a study on human beings with glucosamine and chondroitin that shows a benefit. All of the studies that show benefits to glucosamine and chondroitin are actually performed on dogs. So can that be translate to humans? Yeah, it could. It's not, glucosamine and chondroitin aren't going to hurt you. They're
Right.
not going to cause problems. But like we said from our opening statements in this, there's no way to regrow cartilage.
Right.
That's impossible. So, you're taking these supplements, maybe you help with some of the structure of the cartilage, making sure your body has the building blocks to build cartilage for whatever it can rebuild, which is not very much. Joint health cannot be improved by taking a pill or a vitamin.
Can be improved by low impact exercises, maintaining weight bearing exercises as well, keeping up muscle strength, and having an active, healthy lifestyle. Just to kind of put it into perspective, with talking about weight and issues and things like that that are coming off of it, every pound that you lose in weight is 4 pounds of pressure off your knee. So if you look at it from the standpoint of a 10,000 step day, so if you lose 10 pounds, you multiply that by 10,000 steps a day, that's 400,000 pounds worth of pressure that you have now relieved off of your knee per
That's
day.
crazy.
And
Crazy.
just to kind of put that into perspective, a fully loaded semi-trailer has a max weight of about 80,000 pounds. So really what you're looking at is about 5 semi-trailers worth of pounds per square inch that you've now relieved from your knee daily. And for the people that use kilograms out there, that's a semi-trailer is about 36,000 roughly kilograms.
Yeah.
Right.
So it's about 181,000 kilograms per day off of your knee.
Okay. So in a nutshell for that, walk, keep healthy, exercise, get your 10,000 steps in.
We all
The
wish.
and something to bring up about the knee, and we discussed the anatomy of it a little bit ago. The knee is sort of one joint, but we kind of think of it as orthopedists. We think of it as 3 different joints because, like Lewis had mentioned earlier, there are 3 compartments. So, the medial compartment is on the inner aspect of the knee, the lateral compartment on the outer aspect, and the anterior compartment in the front of the knee. And each one of those compartments inside the knee has different mechanics, different way weight and force goes through them. So, for example, the medial part of the knee, every step you take, about 85% of your weight goes through the medial part of your knee and only 15% goes through the lateral part of the knee. But every time you walk up and down a step, the amount of force that goes through the kneecap into the femur, that anterior compartment, every step is about 20 times your body weight. So getting back to that obesity, the heavier you are, the more force is going through that joint, and the more likely it is that the cartilage is going to give way or wear out over time.
That's incredible. That's very, very clear. When we're talking about prior treatment, NSAIDs being used, you've got other agents being used by people and by doctors prior to the knee to relieve pain. Are there differences in what people should be taking for their pain relief versus not taking for their pain relief? And are any of those impacting upon the knee? For instance, hiding the pain, more damage?
Arthritis is an inflammatory condition.
Right.
So similar to our body's reaction when we have a cold, right? Or we have some sort, like we have a pneumonia, we have a sinus infection, we have an upper respiratory infection. Any sort of cold, right? That causes inflammation in our body. Our body sees something wrong and it reacts by sending white blood cells there. And then those white blood cells try and take care of the problem. They start gobbling up all the viruses or the bacteria and getting you better. What happens in arthritis is that because the cartilage is starting to wear away, it starts creating microparticles of cartilage, and like atomic sized particles that we can't perceive, but our body knows is there, and our body knows is not supposed to be there. So what happens is that sets off an inflammatory reaction inside the knee. The same white blood cells that help you fight an infection, those white blood cells now go to your knee and they start trying to gobble up all the little cartilage particles that are floating around your knee. And they release their own sort of substances that increases the inflammation. Now your body thinks that it's helping you because it sees these little pieces that aren't supposed to be there, and it's gobbling them up and creating inflammation, because that's how our bodies heal. But what our bodies don't know is that by sending off these signals and actually gobbling up the cartilage particles that are floating around, it's actually decreasing the amount of time that it takes for the cartilage to wear away, because all these inflammatory factors cause breakdown of cartilage.
Mm.
So it becomes this vicious cycle here where whatever the cause of the arthritis, whether it's wear and tear, something that we call osteoarthritis, or if it's an inflammatory condition like rheumatoid arthritis or lupus that can cause breakdown of a knee joint, battling that inflammation is really key to successful arthritis treatment, because that's how our body is responding to the insult of the arthritis. And basically, patients with rheumatic disease like rheumatoid arthritis and lupus, they're taking disease-modifying medications at this point in time. That's the standard of treatment. And what do? Those decrease the inflammation. And before we had the disease-modifying treatments for inflammatory arthritis, we use steroids. And what do steroids do? Steroids decrease inflammation. So, the principle medically is relatively basic. We need to decrease inflammation to increase the longevity of the cartilage that's damaged inside the knee. In patients with, osteoarthritis or wear and tear or malalignment syndromes to their joint that's causing the breakdown, we can use oral steroids just like we use in inflammatory arthritis, but we also use non-steroidal anti-inflammatories that have much less side effects than the prednisone, than the typical oral steroid. So ibuprofen, naproxen, diclofenac, all very common non-steroidal anti-inflammatory medications are really the hallmark of treatment for arthritis, because you're actually intervening and stopping the disease process.
So the question I had next was around, what are the indicators to say, okay, I now need a knee replacement? How does a patient, they go to their GP, their primary physician, complain of the pain, they get an X-ray done, it shows, walk us through that kind of that journey with that. What does that look?
Sure. So I think I'll preface everything here by saying that nobody dies from knee arthritis. This is not something that is a condition that needs immediate attention. This is not a coronary artery blockage or something like that. It's a quality of life issue. And as you go through the steps of dealing with knee pain, arthritis, and things like that, patients may have exhausted things like the non-steroidal anti-inflammatories, the physical therapy. They may have tried a cortisone injection or one of the various gel injections, the hyaluronic acids. Some patients even refer to them as chicken shots, because the first ones that came out were actually processed from the cone of a rooster. So you hear different lingo coming through the office about it. Knee replacement surgery is done as a last resort for those people that have failed conservative management and their quality of life suffers enough that they want to do something about it. There's kind of two options. You can change your life to suit your knee, or change your knee to suit your life. And when it gets to that point and you failed everything else, that's when you start to look at the definitive treatment. Everything up until knee replacement surgery is sort of palliative. It doesn't fix the underlying problem, but it treats the symptoms. And if you're comfortable, there are some people with mild arthritis or moderate arthritis, and it doesn't really bother them. They get aches and pains once or twice a year, and it lasts a couple of weeks, and they take some medicine, and then they feel better. And, for other people, it might be in the weight-bearing portion of the joint. They just may be more susceptible and more active to the process. And it's crippling, it's debilitative. They can't get up and down out of a chair. They can't walk upstairs. They can't walk, more than 10 minutes without having to sit down. So it's a very individual choice based on your lifestyle and the quality of your life. You can't definitively say one way or the other, you must have it, because it's not a must. It's a quality of life issue.
Right.
You've brought up the 3 compartments. So everybody's needs different. So what type of knee replacements do you have to think about for each individual? Because it's not a one size fits all. And as you said, you've got different load bearing weights, you've got different knee structure. Is the knee replacement selection specifically designed for a particular patient?
Well, before I get to that, I just want to piggyback on what Lewis was saying for a moment. Conservative treatment for knee arthritis works well. It works. There are plenty of patients that come into the office that think that they need a knee replacement, and with appropriate conservative treatment, non-surgical treatment, will never need a knee replacement. Just because you have knee arthritis, it does not mean that you need a knee replacement. We see on TV these ads, laser treatment for knee replacement. You'll never need surgery if we do this. And that's because they're playing the odds. They're playing the odds. They know that, I'm making up a little bit of a number here, but say take every single patient with moderate to severe knee arthritis, only 20% of them are going to need knee replacement. Not all of them, because a lot of people will respond favorably to the non-surgical management. So when you see these ads for non-surgical treatment of knee arthritis, non-surgical treatment of knee arthritis, and the 80% that they treat say, hey, look at our great results, but 20% are going to fail, and they'll send them to a surgeon, and then the knee replacement will fix that issue. So just because you have knee arthritis doesn't mean that you will need a knee replacement. Conservative treatment, which Lewis was mentioning, consists of anti-inflammatory medications. Those are oral, usually for 3 to 6 weeks standing, meaning taking it every day. Physical therapy is huge. When you have knee arthritis, you don't walk properly. Your body creates compensation mechanisms to guard you from that pain. And that creates imbalance in your legs, and that can potentiate the arthritis and have it progress. So physical therapy to make sure that your neuromuscular stimulations are appropriate and you're not activating the wrong muscles helps prevent it. Our muscles support our joints. So building up our quadricep, which is our thigh muscle, right? Our hamstring is the thigh muscle in the back of our thigh. Those are the main muscles that control our knee. Making sure that you have strong quadricep and hamstrings takes the pressure off of the inside of the knee, because your muscles are taking the weight, not the bone and not the cartilage. So having strong quadriceps and hamstrings may prevent you from needing a knee replacement in the future. These sorts of measures. And then was also mentioned these gel injections. And like we spoke about previously with the glucosamine and the chondroitin, those are components, those are the molecular components of a substance called hyaluronic acid.
Right.
And hyaluronic acid is the main lubrication inside the joint. If you touch hyaluronic acid, it feels almost like motor oil, like a thin motor oil. It's a pretty remarkable substance. And what we're able to do is, the initial ones were able to be harvested from the crowns of roosters, but now we're able to make it in a laboratory and have it match exactly human hyaluronic acid. And so we're able to now inject human hyaluronic acid into people's knees, and that's giving them back their lubrication. And we didn't know, but we know now, after using this for 15, 20 years, not only why does hyaluronic acid work? Not only is it a lubricant, but it has potent anti-inflammatory effects. Boom, right? We talked about that. Get that anti-inflammatory effects in there, decrease the inflammation, patients are going to feel better. What patients fail conservative treatment? 1, non-compliant patients. 2, patients with malalignment somewhere else. Because you can treat that knee arthritis as much as you want, but if your hips are at a bad angle, that knee arthritis, no matter what you do, you're going to have weight in that knee where it's not supposed to be, and that's going to wear down.
The three compartments are very, very important, and because people don't know, obviously. And I'm saying that with the tongue in cheek because there is a lot of advertising, especially in the United States, on surgical and preventative techniques being used. How important is the second referral question to ensure that you're not being led astray with a promise of things to come that may not be necessary at this stage?
Yeah. Your best bet for these sorts of things, well, like anything else in medicine, right? You want to go to the providers that see that condition the most.
Yeah.
Right? If I have lung cancer, I'm not going to my general practitioner to treat me for that lung cancer. I'm going to an oncologist, and I may even go to a specialist in small cell carcinoma. So the subspecialties get narrower and narrower, and those providers see that problem more. Now, I can't speak for every provider that's a subspecialist, but there's a higher chance of having someone with a high level of expertise if you go to someone that only sees that problem.
Right. And
Or
patients need to do their homework, go and find the appropriate clinician. And John, it's like what Philip said yesterday, is to get a second opinion, right? I think it's important.
So people think of orthopedics as a specialty, but within orthopedics, there are multiple subspecialties. One of those subspecialties in orthopedics is called adult reconstruction. And adult reconstruction specialists are the ones that specialize in knee and hip replacements. All they do are knee replacements and hip replacements. And if I was going to have a hip replacement or a knee replacement, or actually one of my close family members recently had, and what I do, I referred them to one of my partners that's an adult reconstruction specialist to make certain that they had the highest level of care. And that's where patients can go. And you need to just remember, cartilage cannot be regrown. So if someone's offering you a treatment that's going to restore your cartilage or regrow cartilage, that's a lie. Because if someone had a way to regrow cartilage at this point, we wouldn't need joint replacements anymore. There's a lot of research labs spending a lot of money on the race to figure out how to regrow cartilage, because the first lab that can regrow cartilage in an animal model consistently
and have it last
and have it be as close to human cartilage as possible, they will make gazillions of dollars.
Okay, so that's a plug for someone that's out there. Learn how to grow cartilage.
There's a lot of research on that. There's been a lot of failure, as Ari said.
Some of the interesting research these days, what they're actually finding, it's finding the right environment for these chondrocytes. Chondrocytes are the name of the cells in our body that grow cartilage, and those are the ones that shut off as we get to adulthood. But finding how to turn them on is really a key. And what they're actually finding is that these chondrocytes in coral, so taking calcium carbonate, which is really what coral is made from, they even took sea coral because it's as porous, as little holes, and putting the chondrocytes in the coral, the chondrocytes grow. Why? They like that environment and they grow. So this is where the research is heading, is how to take that and make it more biologic, because we're able to grow cartilage in a test tube. Translating live into live mammals, we haven't been able to do yet. Yeah.
Back to the question regarding knee and mechanics. We've done the mechanics. We've looked at the inflammatory process. We've looked at the future with chondrocytes. So the knee, the actual knee replacement, how does it work?
Yeah. So like I had mentioned, we think of the knee as just one joint, but it's actually three separate joints. And you can have arthritis of all three joints in the knee, of all three parts of the knee. And that's something that we would call tri-compartmental arthritis, all three. But you can also have isolated arthritis for one of those three compartments. Maybe, when you were younger, you played rugby or something like that, and you fell hard on your knee. and you were out of commission for 4-6 months, but there was no break, and they said, all right, get back to it. But what you really did, why the x-rays were negative, and it hurt so much though, was because you really did damage to the cartilage. And you can't see damage to the cartilage on x-ray. So you may, when you become 60 or 70, you may have just arthritis in the front part of your knee, in that anterior compartment. Similarly, if you were skiing and you tore your MCL and you didn't really get treatment for it, and that compartment, the medial compartment, the inner aspect of the knee, wasn't well supported, you may just have isolated degeneration in that compartment of the knee. So they make replacements for each compartment of the knee as well as for the entire knee, which we call a total knee replacement.
So you can have these different areas replaced specifically without touching the rest of it.
Yes, and the caveat though is that you can't have arthritis in any of the other, or you have to have very, very mild arthritis in the other parts of the knee. If you have, severe arthritis in the medial compartment and, moderate arthritis in the anterior and lateral, an isolated medial replacement may not be the thing for you, because the other stuff is just going to break down over time anyway, and you're going to have to come back and get it redone. But, if you're a 40-year-old person with isolated medial compartment arthritis, maybe you get just a medial compartment replacement. And then you say, all right, well, when I'm 60 or 70, I'll get the whole thing replaced. But if you're 60 or 70 already and you have isolated medial compartment arthritis and there's moderate in the other ones, in the other compartments, well, then you're probably going to get a total knee replacement, because at some point in your lifetime, everything else is going to degenerate.
What types of knee replacements are actually available? Like, do you have robotic? Are there custom made ones? What are the different types? And again, does it vary depending on where you are in geography? Like, I'm in Canada, John's in the US. Is there a difference, or I have no idea?
Yeah, I mean, for the most part, knee replacements around the world have very similar sort of technology. The human knee is the human knee. And if you're going to replace it, you want a replacement that most closely mimics the human knee. There are, I think we have to separate things a little bit. You asked about robotic, but then at the same time, the question also sort of posed the different types of knee replacements. Robotic is a technique. So we have to sort of separate the types of knee replacements with the technique of putting in and doing the surgery. The type of knee replacement you put in can be done with any technique.
Okay.
It just really depends on the surgeon and the surgeon's preference and how they like to do it. But the basic types of knee replacements, we've already gone over the unicompartmental, meaning one specific versus the total. Now what we're going to do is we're going to kind of drill in on the different types of knee replacements that are total knee replacement. Total knee replacements involve resurfacing the knee with a combination of metal and plastic. Knee replacements involve an incision over the front of the knee, getting down into the knee joint, and then actually using a saw to cut away the cartilage that's damaged. So you use a saw that can make a very, very thin little cut, just a few, maybe an eighth of an inch or less, to take off that thin layer of cartilage and a little bit of the bone underneath it. Once you do that, now you shape the bone to be able to accept the knee replacement. The knee replacement always has metal for the femur. So the bottom part of your femur, the thigh bone that makes up the knee replacement, that gets a metal component put over it that looks exactly like your normal knee, except it's made of metal. It has the same notches, the same grooves, the same everything. It's anatomically created. Nowadays, they used to kind of try and guess a little bit. Nowadays, the manufacturers are all 3D printing these. They create a model. They look at 10,000 cadavers. They scan them, and then they do a mathematical average of what an average one looks like, and then they create different sizes. Size 1, size 2, size 3, size 4, because people come in different sizes. So the sizes change as someone gets bigger, just like your tires change on your car as your car gets bigger. The bottom part of the femur is always metal.
Okay.
The top part of the tibia is always a combination of metal and plastic. So the top part of the tibia that makes up the knee joint, again, same thing. We take a saw and we saw it completely perfectly straight. We get rid of all the ridges, any of the arthritic sort of divots that may be there. We make it completely smooth. And then what we do is we put a metal base plate. So that's a metal plate that sits on the surface of the top of the tibia, just like a plate sitting on your table. It just sits on top of it. And then on top of that, a piece of plastic gets popped into it. It locks into it. And that's something that we, in orthopedic, we call it the poly, because it's made of polyethylene type of plastic. And what your knee joint now is, what articulates with the knee joint, the bottom part of the femur is metal. The top part of the tibia now has a plastic surface. And that surface, that metal surface and that plastic surface are highly polished and highly, highly smooth. I mean, some of the smoothest surfaces that our technology can manufacture in society are used for knee replacements. And the reason why that's important, because the smoother it is, the less wear it will perform. Any microscopic irregularities to a knee replacement, that metal is on plastic, something relatively hard on relatively soft, is going to cause it to wear faster. So you need these to be highly polished, highly smooth surfaces, and that's what becomes the articulation for your knee to bend, metal on plastic.
Okay.
The last part of the knee replacement, of a total knee replacement, is the kneecap or the patella. The underside of the patella has cartilage, just like every other part of the inside of the joint. There's one of two ways that surgeons deal with the kneecap, the patella. One, if the arthritis is mild but not too bad on it, you don't have to do anything to it. Just leave it the way it is. And that kneecap now, instead of sitting up against the bone and the cartilage, it's now sitting up against the metal of the knee replacement. And that seems to do okay and last just fine. If there's bad arthritis on the underside of the kneecap, you resurface it with plastic. We call it a patella button. And that recreates the joint surface of the kneecap. So now your medial and lateral compartments have metal on plastic for the articulation, and your anterior compartment also has metal on plastic. So that's a typical total knee replacement. So those are the broad brushstrokes. As far as pretty much all knee replacements are going to be a metal distal femur, metal of the bottom part of the femur, metal and plastic on the top part of the tibia, plus or minus plastic on the underside of the kneecap.
And how long would depend upon the patient and how they treat their knee afterwards. But what's the average length of time that a knee replacement would last?
Well, the thing with knee replacements and their longevity is that we know that the knee replacements we put in 25, 30 years ago are lasting 25, 30 years. What we don't know is how long the knee replacements we put in today last, because none of us can tell the future.
Right.
So we assume that they last at least 25, 30 years, because we assume that our technology now is at least as good as it was in the 90s and the early 2000s, but we're pretty certain we're better than we were in the 90s and 2000s. So we're assuming that it can last 40, 50 years. We just can't say that to a patient because we haven't gotten that far yet. Yeah. So as time goes on, we're seeing that these things are lasting longer and longer, but we can't quite make that statement yet because we haven't had that amount of time with the current technology.
I'm just thinking now, going back to your tooth analogy, and I've had a couple of implants, and one implant actually the body rejected it. Is this a situation potentially with the knee? Is that you go to the trouble of putting the knee in? Is there a chance of a rejection to that metal or to the plastic?
Not usually. Usually when the mouth and a dental implant, the analogy carries, but it's a little bit of a different environment because the mouth has its natural sort of bacterial load in there. And that's usually when an oral surgeon, I've spoken to them about this, so I'm speaking with some knowledge here. Usually when an oral surgeon says that the implant has been rejected, it's because there's some micro-infection in there that your body just wasn't able to control. And then the bone when they put those screws in for the implants into your jaw, those have to get bone to grow into them. If your body's not fighting the oral bacteria appropriately, the bone can't grow into it, the screw loosens and falls out. That's how your body rejects it. It's not usually an allergic rejection, like your body couldn't tolerate it. It's an infection thing. And the same thing happens in knee replacements, except that the knee is a completely sterile area. Now you're opening it up, you're doing surgery on it, and you're putting in a knee replacement. The components to a knee replacement, the titanium and the plastic that knee replacements are made from, in general, aren't substances that the body is allergic to. Some knee replacements do have cobalt chrome, and cobalt chrome people can be allergic to. If you're a person that wears costume jewelry and you get black bands on your fingers, for example, or on your ears after a costume jewelry ring or a costume jewelry earring, that's a sign that you probably have a nickel allergy. And nickel is the primary component, one of the components, not a primary, is one of the components of cobalt chrome. So, if you're a person that reacts to costume jewelry, then you should definitely let your surgeon know, because that may create inflammation in the knee afterwards. But again, that's extremely, extremely rare. The most likely reason why a knee replacement goes bad in the short term are one of two things. One, infection, and that every surgeon, no matter how good or how bad, is going to get an infection every once in a while. I used to have a mentor, and he used to say, if you operate, you're going to have complications. It's inevitable, but you're going to see it, right? I mean, the chance of winning the lottery is way less than that, and we see people win the lottery all the time on TV. This is like the bad lottery to win, unfortunately. And so it's extremely, extremely rare complication, but they can occur and infections can occur. So malalignment of the components is number one, why early revision may be necessary, and two, infection.
And 3, if they don't have the right surgeon, such as yourself.
Well, that goes with, the malalignment of the components.
Can I ask you a question regarding bone cement? Is that common in a redo? Is this something that still happens with the knee?
Technology, and I'm glad that's an excellent segue, John, because that's the next thing that we have to discuss as far as, other options, so to speak, when you're getting a knee replacement, or other things that a surgeon may or may not do. Most knee replacements still are secured in place with cement. Polymethyl methacrylate is orthopedic cement, PMMA, initials. And I don't know the exact stats, but I definitely know a majority of knee replacements put in the United States are still fixed in place with cement. They have the longest track record of positive outcomes. And some surgeons say, listen, I'm used to doing it. It's the way I've done it my whole life. My patients do great. I'm going to continue with the cement. And there's nothing wrong with it. There's nothing wrong with it. Some surgeons think, well, the issue with the cement is that cement can loosen, right? Just like in your driveway or in your bathroom. Think of the cement that we use in knee replacements and hip replacements, not as like a glue holding things together, but more of a grout, filling in any spaces. So just like in your shower, right? The grout on the tiles can wear away over time. And that can happen inside your knee. So surgeons say, all right, well, I don't want the chance of my grout that I'm putting in there wearing away. There has to be a better way, a more biologic way. And the other way to get knee replacement components fixed to a person is what we call press fit or bony ingrowth. So we actually change the undersurface of the replacement to have tiny little pores. And those tiny little pores allow bone to grow into it. So when we put the replacement in, there's an immediate fit just from the kind of square peg round hole. You could get an immediate fit there where you're able to press it in and it's stable. And then over the course of 6 weeks, your body actually grows bone that grows into the implant and makes it part of your body. So you're not relying on an artificial substance like the grout to hold it in place. It's part of your body. Bone has grown into it. And that's one of the reasons why knee replacements are lasting longer than ever, and why we're pretty certain they are, is because we're not necessarily having to rely on
Cement.
station techniques other than the body's own ability to grow bone.
Mm.
Is what you just mentioned, is that common? Like, again, sorry, because I'm in Canada, my mom just had a knee replacement. I wish I'd had this knowledge prior to her having it. But anyway, regardless, what you just mentioned, is it common globally, or is it just a technique that's used in certain centers? Or
No, the term that they use is press fit knees.
yeah,
And press fit knees are, in our institution, even though around the country people do more cemented than press fit, in our institution, our surgeons do more press fit than cemented,
okay,
because it allows for faster surgery. Because you don't have to wait for the preparation and the of the cement and the cement to cure and dry. And it also allows for a more, like I said, a longer longevity of the replacement. So there's not much, the literature hasn't panned out that much difference between cemented and press fit. There is the real difference between the two is that patients get off the operating room table faster because you're able to skip a step, so to speak, because you don't have to do the cement step, which can take 15 minutes during a surgery. So that's the real, as far as long-term outcomes of cemented versus press fit, that still has to be borne out in the literature.
and could there be less complication rates as a result of press fit versus cement, or not known, or not really?
Well, you're sort of trading one thing for another. For example, in an older patient, maybe a patient that's in their late 70s or early 80s, and in particular a woman that may have osteoporosis, a press fit knee relying on their bone for fixation may not be the best idea because they already have poor bone quality, and you can get subchondral fractures, you get little micro fractures of the bone that remains, and that may not be the best idea for an osteoporotic woman in their late 70s, early 80s undergoing a knee replacement.
Right.
Whereas a more active 55, 60-year-old, the press fit's probably the right surgery for them because they have better bone quality. So it's not a one-size-fits-all type thing. And that's why you want to go to a surgeon with the expertise and the knowledge that can do all this. You want a surgeon that can do press fit, that can do cemented, that can do totals, that can do unis,
Right.
one compartment. So this way there's no bias from your surgeon as to what the best treatment is for you.
So the person had the operation successfully done at Northwell Trauma Health. What's the next step? Is the recovery?
That's a really good question. And more we're realizing that early motion, early weight bearing is pivotal in better functional outcomes and recovery. The ideology and the way we think about rehab, getting patients out of the hospital is changing drastically. We're now doing more especially with the younger, more healthy population. We're doing more with getting them out of surgery same day, getting them up and walking, and initially starting physical therapy post-operatively, depending on the surgeon's preference, potentially day one after a knee replacement. So you undergo surgery, you're up and walking the same day, and discharged from the hospital with the next day starting physical therapy.
Yeah, so much so that about 80% go home within 24 hours and 40% go home the same day. And that's, again, selecting. Not every patient is going to be a patient that's going to be able to go home within 24 hours. But with the appropriately selected patients can be out of the hospital that quickly due to improved anesthetic technique and improved pain management technique. Sorry to jump in.
No.
No, and that brings up a good question, right? Because we've had a discussion, and I noticed that you've had several publications on pain management post-operatively, and this is one institution that uses a lot of non-opioid. So for pain relief post-operatively, is this decision being made for each individual patient?
It's both individual and it's preferences. We know the risks of narcotic use. We know that they work in immediate postoperative pain, but long-term, there's a lot of issues with dependence, decreased efficacy, and things like that. And across the board with all orthopedic surgery, not just in knee replacements, the thought process is a multimodal therapy works a lot better because you're covering pain from different sources. So we think of pain as just being the ouchies associated with it, but it's what goes into causing the out. Is it inflammatory? Is it a neuron firing issue? Is it a combination of all of the above? And we know with surgery, it's a combination of everything, right? Anytime you make an incision in the skin, you create an inflammatory response. So how do we attack pain now? We attack it from multiple places. We give people an anti-inflammatory. They're sent home on, if they're able to tolerate things like naproxen, Celebrex, meloxicam, as part of their regime. We're giving them medications like gabapentin to decrease neuron firing and nerve-related pain from having surgery and having, nerve fiber endings in the skin and muscle cut. We're also attacking it with regional block to decrease pain reception immediately post-operative by blocking pain at the actual nerves themselves, all leading to better post-operative outcomes because now you're not playing catch up to it.
Right.
In our institution, we start the post-operative pain management before the surgery. So when patients are in the preoperative holding area, they get a dose of Celebrex, which is a non-steroidal medication. And as the surgery is starting, as the anesthesiologist is anesthetizing them, which we'll get to in a second, they're getting a dose of dexamethasone, which is a type of steroid. Again, decreasing that inflammation, right? We know that the surgery is going to cause inflammation. We want to start knocking down that inflammation as quickly as we possibly can. So aside from the pre-medication, the type of anesthetic has also been shown to help decrease post-operative narcotic intake. And a decreased post-operative narcotic intake is one of the ways we get patients out of the hospital faster. If we're giving a patient high doses of morphine or oxycodone, they're not going to feel like getting up and walking. As soon as our patients hit the recovery room, within 30 minutes, there's a physical therapist there getting them up and getting them starting to walk. So other things that we do to help control pain post-operatively is the type of anesthesia. We use spinal anesthesia unless there's some sort of contraindication, some reason a patient can't get spinal anesthesia. But we're using spinal anesthesia because there's less grogginess and less tiredness after surgery. Patients are more likely and more willing to get up and out of bed afterwards because the spinal anesthesia doesn't put them to sleep completely, just makes them numb from the waist down. And that can last. So when patients wake up from surgery, when you have general anesthesia and that anesthesiologist shuts off the anesthesia and wakes you up, there's nothing blocking your pain. You're going to have, full pain. If if you get spinal anesthesia, you wake up from the surgery and you're not feeling anything. And then that spinal anesthesia wears off slowly and the pain is way more tolerable. In addition to anesthetic technique, we're using injectables, what we call kind of a pain medication cocktail at the end of the surgery, right before we close. We're using some typical local numbing medicines like ropivacaine, which is a long-acting kind of Novocaine that we put in. But we've also found that ketorolac, which is an anti-inflammatory medication, that works really well when we inject it. So we're injecting anti-inflammatory medication directly into the soft tissues inside the knee as we're finishing up. The other medication is clonidine. Clonidine works on nerve endings to make them less sensitive. So as we're leaving and as we're closing up a patient, we're also trying to help set them up for the need for less narcotics. And then, yes, getting them out of bed quickly, getting them walking quickly, letting the patients realize, hey, you're up and walking. And this starts from the second this patient goes in and gets evaluated for a knee replacement. You're not going to need rehab. You're going to go home. This is what's going to happen. They're going to get you out of bed right away. Oh my God, you can get me out of bed. Yes, this is exactly what's going to happen. Every single patient that you see here in this office getting a knee replacement, they're all going through the same exact thing. Good results with knee replacements occur with consistency and regimen, and making certain that every single patient gets the same treatment and the same treatment algorithm is the way that you can make certain that you have the best results possible. And I give a ton of credit to my colleagues that are joint replacement specialists, because even though we joke around a little bit, hey, you guys are only doing a couple of surgeries, the reality is that they, like a NASCAR pit crew. You go in there, everything is exactly the same every single time. Everybody knows their job. Everybody knows exactly what they're going to do. Everybody executes it and gets the patient, better.
Ari, you just went through the algorithm kind of saying that, every patient gets the same, which is wonderful. And I know that if I need a replacement, I'm going to come down to you in the United States. God knows if I can afford it or not. But anyway, does age play a factor? I.e., does your algorithm, regardless of if a patient's like 70, 80 or 30, 40 years of, I shouldn't say 30, 40, but 50, like same kind of algorithm that you provide to them regardless of age?
Yeah, it's an algorithm. It's not cookie cutter surgery. So there's a full assessment that takes place of that patient pre-surgery, both physical capabilities by a physical therapist who assesses them, but also they go through a full medical workup. And patients with cardiac problems or respiratory problems that may need extra monitoring after surgery. These are patients that may not be candidates for getting home from a hospital in 24 hours after a knee replacement. So we try and make certain that every patient has a program or a plan in place best suited to them. Now, sometimes we tell a patient they can go home, and, the next morning after surgery, they're like, there's no way I'm going home. I live by myself. I could barely walk. All right, well, stay another day or so. It's not, we're not forcing people to do these things, but the expectations of what they're going to go through are being set from the second they walk through that door. Okay. Additionally, what we do is all patients go through a joint replacement education class about a week before surgery. We have an online course. It's via, Zoom, and patients are sent emails, and there's staff that follows up with them, gives them a call, make sure they log on and make sure they see these so they know. So you get good outcomes by setting expectations, like with your kids, right? If they're expecting a car for their 18th birthday, but you only plan on getting them a Hershey bar, they're going to be upset. But if you tell them, listen, all you're getting is a Hershey bar, they might be okay with it.
Lewis knows the feeling.
That is absolutely fantastic. So comprehensive. Rehabilitation. You've spoken to it. And again, I have to bring in my mom, like she went through it, but still there were issues. So I know it's critical. I know it's important. Is there a length of time that you guys then say, okay, X amount of weeks or months, or what does the rehabilitation post look like?
I'm going to preface everything with everybody rehabilitates at a different rate. Factors that go into it, general health status, weight, activity level prior to surgery versus if you are sitting in a chair for 18 hours a day before surgery, you can't be expecting that all of a sudden you're going to get a knee replacement and day 2 you're going to be walking a quarter mile. And that falls into expectations and having that discussion with your patients. But in general, one of our former colleagues used to say that 60% of recovery occurs within the first 6 weeks, 90% by about 3 months, with being 9 months to a year to fully adapt to having this knee replacement. You're changing mechanics. Somebody who's limped with knee arthritis for years and years all of a sudden has no more knee arthritis, and deformity that has been caused over time with wearing away is now corrected. Your body now needs to get used to walking a new way.
Normally.
For everybody, that response is a little bit different. Also, people have different tolerances to pain, different mindsets. Mindset is very, very key. Those that are able to push through some general discomfort associated with post-operative pain tend to do better than people that are very sedentary and are unable to sort of get themselves to move. But most people by about 6 to 9 months are doing the things that they want to do, walking. They may not necessarily be back to playing pickleball or tennis or day-to-day living and stairs, and they'll definitely be having a better quality of life. The biggest turnaround is within the first 6 weeks to 3 months.
And so now the patient has one bionic knee, brand new, as I like to say, one older knee. Well, what's is there an impact to the older one because the bionic one, how does that work?
Well, actually, a lot of people, before they undergo knee replacement surgery, have pain in both knees because one knee is affected and the other knee is compensating.
Right.
So that can occur. In general, patients feel relief in their contralateral in the other knee that's not getting the knee replacement once the arthritic knee is replaced, because they no longer have to favor the other side because the pain is gone. Knee replacements are any joint, whether it's a hip replacement or a knee replacement, are very, very good at getting rid of the pain because you're getting rid of the arthritis. The thing that's causing the pain is the inflammation, and that inflammation is being caused by the breakdown of the of the cartilage. You're getting rid of all that. All that cartilage is gone. There's no more of those products floating, those breakdown products floating around in the knee. So patients feel really good after joint replacement surgery once the pain from the actual surgery settles down because the pain generator is gone.
So we're a little over time in this session on knees, and I think we could talk more about the knee.
I could go for another hour or two.
I know, maybe we should, but how do we summarize what we've discussed?
So thank you guys for having us on. It's always a pleasure. There's one thing I can talk about, it's orthopedics. There's no doubt about that.
Top 3 key takeaways from both.
Yeah, the most important thing is one, don't disregard a surgeon's telling you that you need a course of conservative treatment first. Non-surgical treatment can be effective and long-lasting. So that's one. 2, if you're going to have and need a knee replacement, make certain the higher the volume of knee replacements that surgeon and that center does, the better the outcomes. That's been proven not only in the United States, but all across Europe as well. The higher volume surgeons and the higher volume hospitals have better outcome with joint replacements than the lower volume ones. And finally, don't disregard physical therapy on the back end. You need to make certain that you follow your surgeon's instructions and participate in an aggressive post-operative rehabilitation program, because you will still have deficiencies and pain if you don't rehabilitate the muscle supporting that knee appropriately.
Okay. That's great.
That's great advice, Ari. And as usual, we want to thank you and Lewis for this hour on the knee replacement. And I hear that there's a title already being developed for this session. And just on behalf of MedInsights and all our listeners, thank you very, very much. And we really appreciate all the work that you and the team at Northwell Health are doing. MedInsights Unleashed disclaimers. This podcast is for general information purposes only and should not be considered healthcare advice in any way. The podcast is not intended to replace professional medical advice. The use of the information and material linked to the podcast is at the user's own risk. MedInsights Unleashed is not responsible for any losses, damages, or liabilities that may arise from the use of the podcast. Importantly, please consult your healthcare provider for individualized guidance and treatment. Thank you, and we look forward to you being with us on the next MedInsights Unleashed podcast.